So, shall we begin now? Yes. So,
Yeah, live.
yeah. So, a very good evening to everyone. I am Dr. Gunjan, and I take this opportunity to welcome you all in this DOS postgraduate education program. Today is the 46th lecture and second lecture on the STRABISMUS series. This lecture will be taken by Dr. Abhipsa Sharma. The topic of this will be strabismus relevant physiology and principles of ocular alignment. So a bit introduction about Dr. Abhipsa. She is a consultant in ASG Eye Hospital, Jodhpur. She has done her MD from AIMS Delhi, and following that she has done her fellowship at LV Prasad, and she was an ex-LV Prasad Eye Institute consultant. She has several awards and publications to her credit. And today we have with us our moderators, that is Dr. Anita Ganguer, who is a consultant ophthalmology at Gangaram Eye Hospital and has been a senior resident and senior research associate at RP Center, Delhi. So without much ado, I think Dr. Abhipsa, you can begin your lecture.
Thank you for inviting me for this lecture. I hope I will be useful to the PG residents. I'll just share my slides. Are you seeing the presentation mode?
Yeah, yes, we are seeing the presentation mode and you are well audible also. You missed out.
Okay. Okay, so I will be talking about relevant physiology of extraocular muscles and the principles of ocular alignment. So our learning objectives will be physiology and mechanics of extraocular movements, ductions, versions, and vergences. And I will be talking about basic definitions pertaining to extraocular muscles, the laws of ocular motility, and a little bit touch up on the supranuclear control of eye movements. I will also be talking about basic histology of extraocular muscles and extraocular muscle pulleys. So, basically, we are talking about a spheroidal body. So, if you can see, I have a ball here, which I will be using to represent the eye. And according to the basic kinematics, there are three axes which you can have for this eyeball. So, this is the vertical axis or the z axis around which the eye can rotate in this direction, whether it is inward or outward. The second is the x-axis or the horizontal axis around which the eye can move up or down. And again, we have a third axis, which is the anterior-posterior axis, which you can see in the third diagram. And around this, there is a possibility of rotatory movements. Okay, so there are translatory movements and there are rotatory movements. So any freely suspended spheroidal body can be reduced to a combination of one or more of following 6 movements. Again, these can be sideways, up or down, or forward and backward. These are actually translatory movements, and rotatory movements are the movements when the body can rotate around a vertical, horizontal, or an anterior-posterior axis. So coming to the eye and talking about the center of rotation and the equatorial plane. So the center of rotation, as you can see here, is the center from which all these axes are passing, and this has been assumed to be fixed, but now it has been indicated that it is actually a semicircular plane along which there is the center of rotation, and around this center of rotation we have different eye movements. Again, in primary position, this center of rotation lies around 13.5 millimeters behind the apex of the cornea. So behind the apex, 13.5 millimeters in emetropes, this center of rotation will lie. And in myopes, it lies a little bit behind, that is around 14.5 millimeters. So if you have to consider for practical purposes, this line, if you see that this is the orbit, so this line and the center of rotation will lie in between the line connecting the lateral orbital margins. So this is the basic kinematics of the eye. And again, coming to the equatorial plane. So what is the equatorial plane? The vertical and the horizontal axis, as you can see here, they lie in a equatorial plane, or this is also known as the listings plane. This is fixed in the orbit and it passes through the center of rotation and equator of the globe when the eye is in the primary position. So basically, this will lie like this. So coming to the how the muscle is located as per the eye. So what are the definitions which are pertaining to the muscle? So first thing is we need to know about the tangential point. So what is the tangential point? This is the point at which the center of the muscle or the tendon of the muscle, it first touches the sclera. So that is the tangential point. And the second thing which we need to understand is the arc of contact. So what is the arc of contact? It is formed between the tangential point and the insertion of the muscle on the sclera. What is the muscle plane? This is the muscle plane. So a tangent or to the globe to the tangential point of the sclera is the muscle plane. Okay. And what is the axis of rotation? This axis is perpendicular to the muscle plane in the eye. So what is the basic clinical significance is that this arc of contact, it can be shortened or lengthened whenever the muscle is contracting or relaxing. So the arc of contact changes in length as the muscle contracts, and it is the longest when the muscle is relaxed and its antagonist is contracted, and shortest when the muscle is contracted and its antagonist is relaxed. So coming to the cardinal movements of the eye. So if we talk about a single eye, the movements of a single eye are known as ductions. So they are either elevation, as you can see in this diagram. Second is adduction, that is the movement towards the nose. Third is depression, that is the movement downwards. And abduction, that is the movement towards the temporal side of the eye. So there are various positions of the globe. The primary position is when the eye is looking straight forwards. The secondary position is again abduction, elevation, depression and adduction. And the tertiary positions are when the eye is moving up and in, up and down, up and out, and then down and in and down and out. These are the tertiary positions of the globe. So this, according to this diagram, I just wanted to make you understand what is how the orbit is aligned along with the visual axis. So as you can see, this is the central sagittal plane and this is the superior rectus. This is a view from which we are seeing from above. This is a view from the above and you are seeing the superior rectus and also the globe. So the orbit is aligned along this muscle axis and the visual axis is around 23 degrees away from the muscle axis. So the visual axis and the muscle axis of the superior rectus will make an angle of 23 degrees between each other. So again, when we talk about extraocular muscles, we have to understand how they are making their action in the eye. So coming to actions of extraocular muscles, the horizontal rectus muscles, as you can see, this I will be talking about the actions with this model. This is the cornea, this is the pupil, and this is the superior part of the limbus. And this is the nasal part, and this is the temporal part. So this is essentially kind of the right eye of, like my right eye. So how the muscle is attaching here, this is the lateral rectus on the temporal side, and this is the medial rectus on the medial side. So when the muscle contracts, you have to remember it contracts from its insertion towards its origin. So when the medial rectus is contracting, it will contract towards the it will contracts towards its origin, and it will pull the eye inwards. So it will cause an adduction. Similarly, the lateral rectus muscle, whenever it will contract, it will make the eye towards outside, and it will cause an abduction. But there are also other secondary movements which might or might not be possible. So in case when the eye is elevated, in those cases, both the medial and the lateral rectus will help in elevation. Similarly, when the eye is in depressed position, they will also help in depression. So this is about the supraplacement and infraplacement of the horizontal rectus muscles. Similarly, when you are coming to the vertical rectus muscles, as I have explained before also, so these muscles, if you consider this as the visual axis, the y-axis, the superior rectus is coming and making an angle of 23 degrees with the visual axis. This also you can see in the diagram. So you have to remember that it inserts around in the anterior part of the eye. So whenever it will contract, again, it will contract towards its origin. So it will cause elevation. And as you can see, this superior limbus part of the eye, it is moving nasalwards when it is contracting. So its action is also in cycloduction and adduction. So whenever this visual axis and the muscle axis will coincide, that is, the eye will get abducted. At that time, the superior rectus will cause maximum elevation. And the similar thing goes for the inferior rectus also. It also makes an angle of 23 degrees with the visual axis. And whenever it will contract, it will cause excycloduction, depression, and adduction. So this is how the vertical rectus muscle, the actions are explained. Again, coming to oblique muscles. So how is the superior oblique and the inferior oblique muscles? The functional origin is actually from the anterior middle side of the orbit, that is the trochlea for the superior oblique muscle, and it is inserted posterior to the equator. So what happens is it is going to move the posterior part of the eye whenever it is contracting. So when the superior oblique muscle is going to contract, it is going to cause an encycloduction. And again, when the inferior oblique muscle, which is again coming from the anterior middle part and attaching here at the posterior part, it is going to cause an excycloduction of the eye. Whenever these muscles are whenever the eye is adducted, the muscle axis of the superior oblique and the inferior oblique muscles will coincide with the visual axis, and inferior oblique will cause maximum elevation and superior oblique will cause maximum depression in these. So again, I will summarize. Medial rectus causes adduction, lateral abduction. Inferior rectus as a primary action will cause depression, excycloduction and adduction. Superior rectus elevation, encycloduction and adduction. And inferior oblique, the primary action is excycloduction, secondary being elevation, in adduction, and tertiary action being abduction. Superior oblique causes an encycloduction, depression and abduction of the eyeball. So this is a pretty good diagram to understand how we have to grade the actions of the muscles. So again, I have told you how the visual axis and the muscle axis will align. That will determine in what gaze the muscle will cause the maximum action. So in case of obliques, abduction, in cases of abduction, the two axes will coincide and inferior oblique will cause maximum elevation and superior oblique maximum depression. Superior rectus in the primary gaze and also in abduction will cause maximum elevation, and again inferior rectus will cause maximum depression in primary gaze and abduction. So next comes, after ductions we have vergence. So what are vergence? Vergence are conjugated simultaneous movements of the eye. They happen in both eyes. So these are binocular movements so that the eyes can move in the same direction. So here, this is the primary position. This is dextroversion. This is levoversion. This is circumversion and this is dorsumversion. And here, this is dextro elevation, dextro depression, levo elevation and levo depression. This is how the versions are seen, or this is how you can grade the versions. Next, what we have to talk about is cyclo-version. So what is a cyclo-version? Is whenever you are tilting the eye. So what will happen when you are tilting your head towards one side? So wherever the head is tilted, that eye is going to intort and the other eye, the opposite eye is going to extort. That is how a cycloversion will happen. So there are vergence movements. What are vergence movements? These are movements when both the eyes, they move in the opposite direction. So these movements are basically there to focus on objects at different distances and they enable depth perception. The most important ones are convergence and divergence. In convergence, both of the eyes, they turn inwards or nasally, and in divergence, both eyes, they turn outwards or temporally. So these are the normal vergence amplitudes for any normal person, and the maximum vergence amplitude is for convergence, which is 15 to 20 for distance and 25 for near. So coming to laws of ocular motility. So initially in the lecture, I had explained about the listings plane. Okay, so this is a plane, as you can see in this uh, diagram. This is a plane which includes the x-axis and the z-axis. That is the horizontal and the vertical axis. And it passes through the center of rotation of the equator of the globe when eye is in the primary position. So, according to Listing's law, all the positions of gaze can be achieved by rotations around the axis that lie on the Listing's plane. So, if this is the eye, parallel to the cornea, you will have the Listing's plane. So, this will include the x-axis and the z-axis, but also it will include the oblique axis around which the eye can rotate. So, in this diagram, as you can see, the O which has been represented, this is the oblique axis which is lying on the Listing's plane. And on this plane, you can have all the rotations which happen in the eye. The second is the Donder's law, which states that there is a specific orientation of the retina and cornea for every position of gaze, as again you can see in this diagram. This corneal orientation, it is specific for each position and it is regardless of the path that the eye took to achieve that position of gaze. This is the Donder's law. And before coming to the other two laws of ocular motility, there are some important definitions which I would like to talk about. So what is an agonist? Every contraction of a muscle, it brings about a movement. So for abduction, the lateral rectus is the agonist. So again, medial rectus is the agonist muscle for the adduction. So whatever muscle is producing that movement is called an agonist, and antagonist is the muscle which is producing the opposite of what the agonist is producing. So in case of medial rectus, lateral rectus is going to be its antagonist. Again, synergist. Synergist muscle, synergist is the term, it is used for the muscles of the same eye. It is not for two different eyes. Synergists are the muscles in the same eye that they act to move the eye in the same direction. As previously I had told that for eye to move up, both superior rectus and inferior rectus, inferior oblique will act. So those two muscles are the synergist muscles. Again, for depression, inferior rectus and superior oblique are going to act. Next comes yoke muscles. So what are yoke muscles? Yoke muscles, we are talking about two different eyes now. So if I have to look to the right, if I'm looking towards the right, what two muscles are working? What two muscles are working so that my eye can look towards the right? That is, in the right eye, it will be my lateral rectus, and in the left eye, it will be my medial rectus. So these two muscles are basically yoked in the eye. So synergistic muscles are there in both of the eyes, and they cause the two eyes to move in the same directions. Okay. Now that we have learned about these definitions, there are the fundamental laws of ocular motility. The coming back, the third law is the Sherrington's law of reciprocal innervation. So it states that whenever an agonist receives an impulse to contract, an equivalent inhibitory impulse is sent to its antagonist, which relaxes and actually lengthens. The state of tension in the agonist exerts a regulatory influence on the state of tension in the antagonist and vice versa. So this law has also been proven by electromagnetic tracing studies, in which here, as you can see, the eye is adducting. In the MR, there is tonic activity, and in the LR, the activity is reducing. So this law has been proven by EMG studies. The exceptions are Duane's retraction syndrome, in which there is co-contraction of the lateral rectus and the medial rectus, which can cause upshoots or downshoots and also cause retraction of the eye. And the second exception is the Perinaud syndrome. Third is the Herring's law. The fourth is the Herring's law of equal innervation, in which it states that whenever an impulse for the performance of an eye movement is sent out, corresponding muscles of each eye receive equal innervations to contract or relax. So this basically what I have told about yoke muscles. So this works for yoke muscles. So this is the basic law of equal innervation, and it is also known as the law of motor correspondence. Again, the exception is Duane's retraction syndrome, in which I have told you the medial and lateral rectus can co-contract, and dissociated vertical deviation, in which the most common thing is that the eye will move upwards and outwards, but the other eye will remain straight. So what is the clinical significance? So in cases of superior oblique palsy, we sometimes see an inhibitional palsy in the other eye whenever the eye which has the superior oblique palsy is actually fixating. So in this case, the right eye has superior oblique palsy. Here, as you can see, this is the right eye and this is the left eye. So in this case, the right eye is does not depress properly, so it is a little elevated. It is hypertropic, and this eye is fixing. So in this case, we see that there is, according to Herring's law, in this case, as there is less innervation to the elevation because the depression is inhibited in this case, or the superior oblique is not acting. In this case, because there is less innervation for elevation, similarly, in the left eye, there will be a less innervation for elevation. So in this case, the left eye will depress. So how do we check that this is an inhibitional palsy. We have to cover the right eye so that the left eye comes in the primary position. And then we can see in the ductions that the left eye will elevate properly. Okay. So next we come to muscle pulleys. So muscle pulleys, all the rectus muscles, they pass through a pulley system which consists of a sleeve or a ring of collagen, elastic and smooth muscle fibers. So this structure previously was known as the muscle sleeve. So basically these are the pulley rings as you can see here. These are specific for all the rectus muscles, and the exception is the superior oblique, which has a rigid pulley, which is the trochlea. So the medial rectus muscle has the most fibroelastic tissue and smooth muscles. So these muscle pulleys basically they connect to the orbital layer of the rectus muscle, to the orbital wall, to the adjacent extraocular muscles, and also the Tenon's capsule. And the pulleys, which the rectus and the IO pulleys are made of collagen rings. Just 1 second. I'm sorry, there was a technical problem. So the rectus and inferior oblique pulley, the inferior rectus and the inferior oblique pulley, they make a ligament-like structure here, which is known as the Lockwood ligament. So these basically they form either rings around the muscles or they formed pulley slings. So what is the significance for these pulleys is that uh, they are the guiding for the muscle action. So they constrain the paths of the extraocular muscles, they stabilize the muscles, and they influence the force direction of the muscles. And these pulleys are, because of these pulleys, there is a the listings law is basically followed by the ocular muscles. They also change their position as a function of the gaze direction. That is, for example, if the pulleys of the horizontal rectus muscle, they move posteriorly during muscle contraction and anteriorly during relaxation. So they are basically called the functional origin of the muscle. So what is the clinical significance? The first comes in the pulley heterotopy, in which if the pulleys are not at their correct anatomical position, they can cause an concomitant strabismus, as in cases of myopic strabismus fixus and craniosynostosis. So this photo is for the myopic strabismus fixus patient, in which the eye has elongated posteriorly, and the pulleys of the LR and the SR, they have elongated and moved. The SR pulley has moved medially and LR inferiorly, causing the eye to move in an iso and downward direction. So pulley heterotopy is has to be known before we operate on any concomitant strabismus. And the second clinical significance is the posterior pulley fixation or the Farden suture, in which we fix the pulley with the sutures so that in the direction of the muscle action, the muscle can be inhibited to act, but in the primary position, the muscle will act fully. Next comes the basic histology of the muscles. So the extraocular muscles, they are again made of the sarcomere, the Z line. This Z line indicates the end of the sarcomere, and it is made up of again actin filaments and myosin filaments. And these myosin filaments, they lie between the actin, and when the muscle contracts, these knob-like heads, as you are seeing in this shortened muscle, these knob-like heads interact with actin and they cause them to move along the actin filaments, and they cause a constriction of the muscle fiber. This increase in force that results from this active contraction is actually known as the active force generation of the muscle. Again, the significance lies in these two situations. First is a stretched muscle. So when a muscle, due to some cause, is stretched and maintained for several weeks, what happens is new sarcomeres are laid down, and these allows the sarcomere to return it to its initial optimal length. So sarcomere, we are talking about this. So new sarcomeres are laid in a stretched muscle, and each sarcomere, it returns it to its initial optimal length. Again, in case of a contracted muscle, what happens? If a muscle is passively contracted for several weeks, sarcomeres, they drop out serially, and the remaining sarcomeres resume their original optimal length. So what will happen? This will cause a permanent contracture of the muscles.
And
Muscles can also lose elasticity secondary to infiltration or addition of stiffer tissue, as in cases of Graves' disease or CFAOM cases, and surgical resection. Again, this contracted muscle and stretched muscle, we have to take in account this physiology of the muscles, as the surgical resection or advancement of EOMs which have lost their temporary elasticity. We have to consider that they have to be done in a proper manner so that sarcomere remodeling can reoccur. So skeletal muscles which are there in our body and extraocular muscles, they have a lot of differences. First, the difference comes in the fiber type and structure. So the extraocular muscles, they have a different unique fiber composition, and they have more fast twitch fibers, which enables them to have very fast, rapid, and precise movements. And they have more mitochondrial density. And even in cases of innervation, the ocular muscles, they are innervated by the cranial nerves. And they have a unique motor organization. And here, as you can see, the ratio of nerve to muscle fiber is higher in cases of ocular muscles. Also, skeletal muscles are controlled by the spinal nerves, whereas the ocular muscles, they are controlled by a complex system. It involves the brainstem, the cerebellum, the higher level cortical areas, and this enables precise and coordinated eye movements. Next, coming to what are the types of fibers in the extraocular muscles. So there are slow twitch fibers and fast twitch fibers. So the slow twitch fibers, these are thin motor nerve fibers, and they are multiply innervated. They are large, poorly delineated. So they do not have any conduction of action potential, and they cause slow, sustained tonic contraction of the muscles, and they are predominantly present in the orbital layer. Whereas fast twitch muscles, they have thick motor nerve fibers, they are singly innervated, and they are small, well delineated muscle fibers. They cause the conduction of action potential, and they have fast contraction, that is phasic contraction. And they are predominantly present in the central, that is the bulbar layer of the extraocular muscles. And there again, there are more fast twitch fibers in extraocular muscles as compared to slow twitch fibers. So coming to the final thing, that is the types of eye movements. I will not be going into much detail of this, as this is a very vast topic. I just want to tell about the types of eye movements. The first are the saccades. So if you have to look from one object to the other object suddenly, or a fast jerky movement, that is known as a saccade. So what controls it in the brain is the frontal eye field. The horizontal saccades are controlled by the paramedian pontine reticular formation, and the vertical saccades are controlled by the rostral interstitial nucleus of the medial longitudinal fasciculus. Again, smooth pursuits. So if you are seeing that some target is moving from one to the other point and you have to follow it slowly, so that movement is the smooth pursuit movement. So this is controlled by the middle temporal area and medial superior temporal area and frontal eye field. The third type of reflex is the vestibulo-ocular reflex. So this reflex, it stabilizes the gaze during head movements. So your head is going to move like this, behind, side to side, and it is going to tilt. So what is going to stabilize this movement is the vestibulo-ocular reflex, and it is controlled by the vestibular nuclei. Again, the fourth one is the optokinetic nystagmus, which basically is following a moving visual scene. So basically there is a moving object like an optokinetic drum in front of you. So you have to follow, both eyes have to follow that. So that is the optokinetic nystagmus, which is a fourth type of movement. It is controlled by the nucleus of the optic tract and dorsal terminal nucleus. The fifth type is the Vergence movements, as I have discussed. These are coordinated movements. They help to focus on object at different distances. Like if the object is coming from a distant distance towards you, towards near to you. So that convergence movement will come and will try to focus on the near object that is coming near to you. And the fifth is the fixation. Fixation is basically just maintaining a gaze on a stationary target. So these are the 6 types of eye movements. And this is where I finished my lecture. So thank you. And if you have any questions, you can put them now or you can email me at my Gmail. Thank you.
Thank you, Abhipsa. I think thank you, Abhipsa. I think that was a wonderful talk. And Dr. Gunjan?
Yes, so I think Dr. Abhipsa has covered almost all the topics related to ocular motility. Most of it had already been discussed last time also, so it was just a revision and few more points have been added today. So a very nice lecture, and the model which you were showing was also very nice. Would you like to add something else, Dr. Abhipsa?
I would just like to add, if they have to read in depth, they should read Von Nuden and even Kenneth Wright. So actually, those 2 books, if you read twice or thrice, everything will go into your head. That's what I feel.
Yes, so basically these
For
are
PGs.
the basics which will be forming the or the foundation over which you will be laying the entire strabismus chapter. And once anyone understands them, it will be very simple to understand the strabismus. So any questions do we have?
I think she has covered the entire topic very well. And I don't see any questions as of now. Gunjan, anything that you would like to ask her?
I think she has covered, ma'am, most of the things. So
Okay.
we
Okay.
can end the class.
We can just once check the chat box. Sunilji, if there are any questions, you can please post. Okay. Okay. And okay. Abhipsa, thank you for that wonderful presentation. And as an effort, as per the request of the students, we have decided to compile all the presentations and a PDF. If you could send us the PDF of your entire talk, so that if all the talks are going to be compiled and a whole strabismus module will be sent out to all the students and residents who are registered with us. And as of now, we have almost 1,100 students who are registered with DOS-PEP and are following us on the WhatsApp group as well. And thank you so much, Abhipsa, for your valuable time in preparing this presentation. And thank you, Gunjan, for
Thank you.
Thank you, Gunjan, for moderating the session. Thank you.
Thank you.